this is going to work. No? Get the next slide. Is it switched on? Ah, there we are. Welcome. There we are. Yeah, I think I've done that bit. Okay, right, just on the right. Okay. So, a little bit about our highlights, first of all. So, this year we definitely met our financial targets. We were rated as good by NHSE. We're continuing to progress in delivering our Your Care, Your Future plans and rolling it out with more community services and developing hospital plans. You'll hear a little bit more about that in a moment. And actually, yes, we have had some national recognition. And I think that sometimes, we can be a bit shy of that, but we really have been finalists and won one of the awards with some of our colleagues in terms of our carers work, and also, as I said, we've been rated as good. So I think it's been a very, special year. So a little bit about the long-term plan, the NHS long-term plan. So it really is, got to be targeted and personalised support. And that's very much what we're trying to do here as a CCG. Much of an increase and focus on population health. Now, I'm not going to try and explain population health to everybody, it would take too long. But there is, I think it's pretty simply making sure that we deliver the right care for the right patients as close as home as possible, but actually making sure that sometimes we put more resources to areas where there is greatest need. And I think that is something that you're going to hear much more of over the coming years, because that is central government policy. It's our policy. We really want to lead on fully integrated community care, and quite a bit of what you'll hear about today will be talking about that and about our future colleagues. Really wanting to make sure that we support the NHS workforce. This is a major issue for us in the NHS. It doesn't matter which part of the country you're in, we do really have issues about recruiting workforce. So I think many of you will have heard about the difficulty in recruitment for GPs, but it extends to community nursing, it extends to our acute trust colleagues. It is a massive issue, and we have to be innovative and really have really good practice to attract the best people we can into our area. GPs delivering enhanced services, working as part of primary care networks, once again, incredibly important. Of course, this was announced in January and took full effect in July. We'll hear a little bit more about that later. Better using data and digital technology, absolutely vital. We have, our GP practices are pretty much all operating now on more or less one clinical system. There are some that operate differently. But the interface, the relationship between us, our community providers, and those in the hospitals is a real challenge for us moving forward. And most of all, we've got to make best use of taxpayers' money, more of which I think you'll hear a little bit later. So a little bit about integrated care systems. So during this year, this is all about trying to bring things together so that we get the best value for money. We have been talking in the 3 CCGs about streamlining our governance processes. So at the moment we have 3 CCGs in our STP footprint. So that's also East and North Herts CCG and West Essex CCG. And we want to make sure that we create something across the entirety of our STP patch, which leads to better integrated care. So we've just put up some examples, and I'm sorry if your organisation or name isn't on there. It really isn't intentional. But the intention of this slide is really to show you just how much we care about working with all of our partners. We see ourselves as very much being part of one system. So a little bit about local delivery plans. So one of the ways that I think we have really been innovative and really focused on delivering care as close as possible to people's homes has been looking at how we can offer the best plans locally. And we've sort of put it down into some headings here. So emergency and urgent care, absolutely vital. Frailty, Catherine and others, but Catherine has been leading on that for the STP, and it's no surprise that actually we've been really making great headway with that as a result. Carers, absolutely dear to my own heart, and I think very much dear to the whole philosophy and ethos of our CCG. Care homes, we're doing a lot of work in care homes, supporting them. Joan's putting a hand up at the back from our care home team, because actually supporting them and helping to keep people at home in their nursing home, if that's where they are in their care home, is vitally important. Making better use of medicines management, also absolutely vital. And this extends right the way through from actually getting the best value for money to making sure that we prescribe safely, and also actually, because obviously, there is an issue that we may not have escaped to called Brexit, and we do have a problem with medicines availability. And we are working very hard with our colleagues and nationally to make sure that we inform GPs when there are issues and possible alternatives. And then last but not least, effective resource management. That sounds like an awful lot of jargon, but what we mean by that is actually using our resources wisely. So one of the things that we do as a CCG is look where our spend is and how we can perhaps optimise care. So an example of that would be perhaps somebody, a patient, one of our population who's frequently attending a hospital or frequently attending a GP surgery. But there may be some really good reasons why that is the case. And so what we're trying to do is identify and support those individuals. It might be through the community navigators that I think Tim will certainly talk about a little bit later on. It might be through actually better liaison with the ambulance service. It might be actually wrapping around better community services. So all of those things are absolutely vital. And I think that's enough of me. So I think it's over to Elke. Where's Elke gone? There we are. Okay.
Hello, I'm Elke Taylor. I'm the Deputy Chief Finance Officer for the CCG. I'm just going to give you a very quick run-through of our financial position for 18-19. You'll have the full set of statutory accounts in the annual report, which you will have seen, so this is just as a brief run-through of our performance. Apologies if you can't hear me. This is our total spend for 2018-19 was 856 million on patient services and some on running costs. Just over half of that is spent with acute hospital providers, and of that 456 million, around 3/4 is with the local providers, and by that I mean providers that are in or around our system that our patients use for general district hospital services. The remainder of acute spend is with more specialist providers who tend to be in London. But 12% of our spend is in primary care, 80 million in mental health and learning disability services, and only 1.4% of our expenditure is on our running costs in order to administer the functions of the organisation. I will take you through our financial performance in terms of targets, and Nicholas had already said that we have met our financial targets. We have a number of statutory obligations around our financial performance that we need to meet each year. That includes keeping our expenditure within the resource limit that we have been set. And the resource limit means the allocation that we have agreed with NHS England that we can spend to. We had agreed a surplus of 2.9 million for 18-19. Actually, we did very slightly better than that, and that is, we had some expenditure items where we were lucky enough to find that it was not quite where we anticipated additional spend that wasn't as high as we had feared. Some of it was Brexit, which then of course didn't happen, so that relieved some of our expenditure. What this has allowed us, and it's not to be underestimated what that means, it's allowed us to meet all of the NHS England business rules, because we now hold a 1% cumulative surplus, and that is the first time in 3 years that we've been able to say we meet that business rule. So it meant we've gone into 19-20 with a financial plan that meets all of NHS England's business rules, and that is quite important. We also have to not exceed our capital resource limit. We don't have a lot of capital expenditure. CCGs as a whole don't tend to spend capital. That is generally spent in hospitals. So there's a bit of capital expenditure for things like IT, but it was actually agreed with NHS England that that was classed as revenue expenditure in 18-19. We also have to remain within our cash limit. So we can't spend physically more cash than we have agreed with NHS England that we can spend in any year. and we have to remain within our running cost target. So we have set a target for our running costs, and we do actually undershoot that. So our budget that we've set ourselves is below the target that NHS England have set for us. So we are quite frugal and careful with our running cost expenditure. Just to take you through some of the achievements in terms of financial investments that we've managed to make in 18-19, and something actually I haven't put up there but that is worth saying is our share of the £1.6 billion of additional funding that the Treasury had announced in the autumn of the year before. A lot of that went into acute services. So in 18-19 we received just over 6 million, and that was our share of that additional funding announced by the Treasury, and the vast majority of that actually went to buy additional acute activity. We're also obliged, it's not a business rule, but we are obliged to meet the mental health investment standard, which means we have to spend money on mental health services. We have to invest in mental health services at a greater rate than any other service that we commission. And we have achieved that, which is great news in terms of being able to actually improve and deliver the right local services. Because our financial position has become much stronger, our financial sustainability and transformation has delivered the results we required. It has allowed us to reinstate IVF funding in March 2019, and that's a commitment we had made. And we had committed that should our financial position improve, we would reinstate funding for IVF, and that's been one of our successes. We contribute nearly 14 million to the Better Care Fund, which is a pooled budget with a local authority, and that supports closer working between local authority and health to support people in the community. We have also managed to invest around 1.9 million. That's sort of a collective sum which has bought capacity to manage winter pressures. It's bought services to manage demand on A&E services, and that has certainly worked in the winter of 18-19. We have also invested 1.6 million into primary care. That supports the development of primary care networks, which is one of the targets that has become a focus for 19-20. It's enabled us to create some additional capacity in terms of extended access, and it's allowed some improvements on infrastructure in primary care. And that's a sort of a run-through snapshot of our financial position, and I would like to hand back to Catherine.
Okay, good evening everybody. Thank you. Right. I think it's always quite difficult in my slot to give justice to absolutely everything that we do in the financial year. So I apologise if we've not had time to cover absolutely everybody, but I think also when you reflect back on what you've done over the last 12 months, it also is an opportunity to think back on how much we have done in the last 12 months. So anyway, I'm going to canter through some of the key highlights, and obviously happy to take further questions later on as we go through this evening's session. So, as a CCG, we have 4 strategic objectives. They are objectives that we've had for quite some time around Your Care, Your Future. We change and enhance them every year, or we develop them every year. And I'm going to take you through what that means for us and how we've transformed and how we've delivered on our priorities as a result in those 4 areas in the last financial year. So from effective engagement, I won't read out what there, but we absolutely at the heart of everything that we do, trying to ensure that we improve our engagements with every single stakeholder that you could possibly imagine. It's a huge part of the work that we do and the influence of the work that we do. It doesn't necessarily mean that everybody agrees with everything at all possible times, but we have hoped along the way that we have listened and have evidenced how we've listened in the decisions that we have made. So just to give you some idea of how we do that, we have, and actually after this evening, we have a GP forum event, which is one of those there. We meet with our members' practices at least 3 times a year. We actually have welcomed 2 patient representatives on the board this year, which is fantastic. Jill, who's at the back, and John. They alternate tenure, but both take participation throughout the year in their roles. We have been doing a significant amount of engagement with the local councils. That's not only the district borough council, but obviously the county council. We have a reader panel that do an enormous amount of work. The amount of paperwork that we send them electronically, of course, we should recognise, and I'd like to thank them for the work that they do in trying to make everything that we do very user-friendly, an important part of our work. We have a very strong patient and public involvement committee chaired by Alison, another lay member on the CCG, and also a fundamental part in the way that we function as a CCG. And I'm going to personally try and attend all of those committee meetings because it's really valuable to test out some of the ideas and thoughts and thinking and what it means for patients on the ground. And lastly, we shouldn't forget our staff, which I'll come on to a bit later, but we have a very active staff involvement group that are fundamental in what we're trying to do as a CCG. We can't deliver any of this without the staff that are within the CCG, and just want to say a big thanks to them now at this moment. So, in relation to our engagement, there is a new annual assessment, and we're very proud of the fact that actually we were green in that assessment, a new NHS England one, and actually in relation to day-to-day practice and governance, we were rated outstanding. So particularly pleased with that. We've refreshed our participation strategy, and if you read the annual report or read the annual report in full, you'll see that's weaved throughout everything we've done. And we've sought from feedback from stakeholders and partners to ensure that means effective learning and effective engagement in everything that we do. We've also linked to it was linked to NHS 70, which seems light years away now, but actually it was in last financial year. And we actually developed a network of over 200 health and wellbeing ambassadors. So another network of people who could be champions to try and get some messages out. And one of those messages that they helped us out was with the Help Us Help You Stay Well This Winter campaign last Christmas, which a lot of you would have seen on advertisement or on buses or on Twitter or any other networks that you might be involved in. And then I suppose lastly I want to bring to attention that we do use patients a lot in the service redesign. We try and start and involve them in the process and actually support them in the process because it can be quite a complex process of people involved in how we commission and contract for services. But they have been given some very valuable input in a number of pathway redesigns and also hugely involved in one of the biggest projects that we've done, which is to recommission our adult community services. We did have 4 patient representatives who lived the entire process for 18 months, so all credit to them. Right, transforming delivery. So to give you an idea, and it builds on a little bit of what Nicola said earlier about the long-term plan, but also about the way we've approached the redesign and the delivery and the transformation of the services, which has ultimately helped us do what Elke was talking about earlier and move us back to financial sustainability. So they've been absolutely at the heart of care closer to home. The delivery of services, therefore, in that way. Personalised approaches so that patients are assessed by specialists who aren't necessarily consultant specialists. They can be specialists in all sorts of different fields. And a lot of the new services that I'm going to come on to talked about how particular specialists in that particular area of expertise are now delivering services in the community. So, and as it says there, specialist teams of consultants, therapists and nurses who are now providing more holistic, comprehensive care in the community. We've done a lot about promoting independence and self-care rather than dependence and medicalisation. You're going to hear more and more about that as the long-term plan is delivered. And as we've said, about keeping as much as we can in the community. And as we do all of these changes and all these pathway changes, how do we upskill all the clinicians who are involved and to ensure that they're maximising their opportunities for their patients? Okay, so these are services that have gone live in the last financial year. There is more to come, but musculoskeletal services, respiratory services, gynecological and diabetes, they're all integrated pathways. And what we're particularly proud of are the fact that waiting times for patients who access those services now are significantly reduced. So that not obviously improves patient access and patient care, but also improves when you do need to go to secondary care that you can see a secondary care consultant earlier. So as you can see, we've reduced on average waiting times from 12 to 16 weeks, and in those services are now being seen for their first effectively community outpatient appointment within 4 to 6 weeks. There has been a high take-up of those new services, actually, probably more so than we anticipated, it's fair to say. And as a result, a couple of them have taken time to stabilise. We recognise that. But actually, what we've been trying to do in that process is listening to patients' feedback. How do we improve that? How do we continue to invest in the development of that? And actually, if it is successful and it has been a high take-up, how do we invest further? Okay. Right, these are the new services also in the last year. These are the more recent ones, ear, nose and throat. So ENT, you may hear that of, that's already a live service in the community. Community ultrasound, nutrition and dietetics, ophthalmology and dermatology. So again, all of those are live and were live in 1819. Some at the back end of the year, but they're all available in every single locality, which is another thing that we have tried to do. So in some cases we may have had, for example, an ENT in one locality and nothing else in anywhere else. Now, in some cases, that may mean patients don't want to travel to other localities, but actually you are able, if you want to access any of these services, to go and be offered an appointment in another locality if you wish and you wish to choose whatever suits your convenience. So, as I've mentioned earlier, our ongoing developments, and I have to say, has taken an enormous amount of time, I suspect, and not only for CLCH, but also for us, in a programme of work that we started in 2017, which was the recommissioning of our adult community services. We did award that contract actually in January this year, and at the time we thought, 9 months will be fine for mobilisation period. That's all okay. I know ladies here thinking, whew. But actually, I think everybody's worked tremendously hard to get to this point, and in 2 weeks' time, we mobilise. So no pressure, but actually we're in a good place. We've had a lot of assurance and governance around that, as you would expect. There is a lot more to come because this is an absolute step change, and the pathway and the transformation of what we've commissioned is a long-term contract that really joins up services between a lot of providers. And I know I see quite a number of people in the room who are part of this, and it's really quite exciting around the opportunities that this will create. So, and that includes voluntary sector providers. So we're very proud of the fact that they're with us on this journey. We shouldn't forget, again, there's been a lot of development in 1819 with GPs and access to GPs. This is a national programme, extended access. Some of you may know it is 8 till 8, 7 days a week. It was led by the Prime Minister's Challenge Fund, and the ideas many, many years ago in pilots, of which Watford was one of those original pilots. But all CCGs were mandated to have 100% coverage of 8 till 8, 7 days a week by the 1st of October. It was actually the 31st of March, but it was brought forward. And we shouldn't underestimate, actually, to do that, it's been quite a significant delivery for GPs in order to be able to make that happen. It's delivered through our federations, so our GP collective provider groups. And actually, we have a significant take-up. We're over in the 90% at all time at utilisation. And actually, as a result, we've delivered 27,700 more appointments in the coalface in primary care. We actually also have put in an extra in-hours extended access hub in October 2018 when the West Herts Medical Centre GP small practice closed, but enhanced the extended access by having the in-hours and extended access to ensure that we could continue to support access in that important site. So I think for those of you who read what's going on in the national press, there's a lot of changes around GPs, and I've got some GPs in the audience, a lot of changes in the way that they deliver services and a lot of changes in the infrastructure of how they're set up. Clearly there's the demands that Nick has talked about around workforce, but also their own resilience as an organisation, becoming increasingly difficult in order to be able to sustain what is ultimately an enormous increase in workload. And actually we've been very successful in helping support practices through a lot of hard work from the practices and the primary care team in a number of changes that ultimately have had led to stronger resilience and better care for patients. One of those is a particular vulnerable group of patients in Watford, the Medwell practice, and they've been merged into Upton Road, have now moved into that new building there, and actually are blending really nicely with that practice, and I'm very pleased with the work that they're doing. The 2,200 patients, as I referred to, have been transferred from the West Herts Medical Centre to other surgeries in Hemel Hempstead. We've also taken improvements in Chorleywood practice and the Elms in Watford. We are developing last year and hoping to bring that to life in the coming years, a business case for a Boreham Wood Health Hub, which is actually one of our highest growing areas of demand. We should also note that we have been doing a lot around training, development, international recruitment, and supporting GPs and other disciplines that sit in general practice in order to be able to stay in the workforce. There is ultimately no magic bullet, and some of the ideas that are coming out of the long-term plan and the development of primary care networks do support that, but this is a long journey ahead. But as a CCG, we have invested in an infrastructure in order to be able to support that agenda. And we should also note that we're very pleased that all of our practices, all 58 as there are now, are rated good with 1 outstanding. So part of the reason that we're able to deliver everything that we deliver is the fact that we have a very, very strong, stable, we go through peaks and troughs, but stable GP resilient practices. So Nicholas referred to it earlier, but I just wanted to take on a bit of a journey around what we were being required to do in the last year around primary care networks. It actually has gone live in this financial year, but a lot of work was done in previous year, and we actually did start to support practices in this way in 1819, therefore. So effectively, the national ask is that GP practices come together in groups of population of around 30 to 50,000. They were encouraging to work together more collectively and to provide care in more integrated way with their populations. They have actually formed all 57 practices into 16 PCNs, and each PCN has a dedicated clinical director and dedicated specialist resource, some of which I talked about that was coming in to help support delivery of services. It's very new, and you're going to hear much more about it as we go through, and those of us who follow our journey into 1920. So in preparation for this, in the last financial year, we actually took a decision to start to develop the thinking around delivery at scale. And we invested, as Elke said, £1.3 million in developing primary care networks for pilot projects and to developing the collaboration and thinking in the delivery of services. Practices were able to bid. We received a number of bids, I think over 20 in total, and over 6 projects were supported in the end. You can see the list of them there, but actually there were a variety of different ones, and for good reasons, because it gives us an ability to test different ideas, but also, if it does work, then give us a view then around what we might do and expand for the future. Some of those, for example, have already been expanded. So frailty and the community vulnerable care coordinator, that has now been rolled out across all 16 PCNs. And actually, we're also talking about how we do an expansion of the anxiety service and the Hasty project currently at the moment. So again, it's all being used to test out how we might deliver more integrated services to support populations in the community. Okay, so I'm just going to hand over before I come back to some of the other objectives to some of my colleagues. So Tim, they've got a slide each. So Tim's... Yep. So, do you want to go first?
Thank you. I'm not taking a call. I was timing myself for 5 minutes. I have actually got, I don't know what slides I've got. This is my attempt to try and confuse you. You will have seen all of those words probably if you have been trying to research social prescribing. It's actually an awful lot simpler than that makes it look. And the reason social prescribing is so important is that something like 20% of all the people that GPs see don't need to see a GP. They have issues that are social and about poverty and so on. And this is a slide from the Health Foundation about the difference in life expectancy. And you'll see that the things that affect your health, with the exception of about 10%, are nothing to do with the NHS at all. They're about housing, relationships, poverty. Social prescribing is a really simple thing. And one of the things I would also say is that if you've heard of community navigators, and you've heard of link workers, they are, to all intents and purposes, the same thing. So it's very straightforward. It's all about referring those people who don't have a specific health need or have much more need in the social area than their health needs to a link worker who will spend the time it takes to understand their problems and help them get the support they need, usually from the voluntary sector, and then the range of services that Catherine's already mentioned out there in the voluntary sector. The reason we set up the Community Navigator Service back in 2014 was to solve a number of problems. And One of those was that Herts Help, which is the single point of access to the voluntary sector, felt quite distant to quite a lot of people, wasn't local, and was easier for people who had less need to use than the people we're most worried about. That's called the reverse care law. GPs came to us, Nicholas among others, talking about the need to help those people who didn't have a medical need but were coming to their surgeries and could get better help elsewhere if they knew how to do it. And we talked about the Better Care Fund. That was part of the support to all this. Public Health was starting to look at arts and exercise pilots and how they could help people. And we had carers champions in primary care that were showing that carers who were stressed and under pressure could be helped in other ways than antidepressants and so on. We must have done something right back in 2014, because by 2016 the Navigator scheme was highly commended by the Health Service Journal for its work in redesigning community health services. We didn't actually redesign community health services, but we started integrating the way people work together. And they also won the High Sheriff Award for partnership working in Hertfordshire in 2017. But that's all irrelevant unless we're making a significant difference to people's lives. And the hard data that we have nationally is down on the left-hand side there, particularly a reduction of 28% in GP appointments for those people who have been socially prescribed to. But more important to when I want to get up in the morning is what's down the right-hand side about what clients say about how they've now got a reason to get up in the morning, they're connected to their community, and they wouldn't be here without that support. Give you one example. Jean, who was discharged by her psychiatrist to the talking therapy service, they rang her, they wrote to her, she ignored all the letters and phone calls, and fortunately they had already made a referral to a community navigator. And the community navigator went round 3 days running, knocked on the door, and was finally admitted. And when she was, what she found was that Jean had a pile of correspondence, which included eviction notices. She'd failed to turn up for a benefits check and all the rest of it, and she was about to be evicted. Now, I think it's fairly obvious to all of us that however good your therapy service is, it won't help someone who's about to be evicted. Their mood is not going to be lifted by psychotherapy. And anyway, I'll cut a long story short, once she got the support she needed, including not being evicted, she was able to start dealing with her health problems much better. She didn't end up in hospital, which was one of the risks that would have happened otherwise. And in fact, she started talking about volunteering, trying to get back into work. And in terms of the existing Community Navigator service across Hertfordshire now, which is bigger than the original one, we're dealing with about 10,000 people per year. But as you can see, we've got evidence from SWEMWBS, which is the Warwick-Edinburgh mental wellbeing measure, of an improvement of 11% in wellbeing and a reduction in loneliness of 18% using the Campaign to End Loneliness tool. And the Public Health Referrer Survey showed that overall the rating was very good, with a 43% excellent, 88% very likely to recommend the service. So where we are now is we're working very closely with the primary care networks, who are getting new link workers funded by NHS England across the patch, which we think will be about 4,000 extra cases a year, which is going to make a real difference to, hopefully, the pressure on primary care. Actually, it's 11 primary care networks so far matched with voluntary sector hosts, 3 actively engaging, and 2 who may make their own arrangements. But it's all structured in such a way that we have one single system. A lot of you will be saying it's very confusing knowing what is out there in the voluntary sector and how to get it. But basically what we have created with Herts Help, with the County Council and other partners, is a single system, which I'm not expecting you to memorise from that picture, but these slides will be available and we can talk through, if any of you are still confused at the end of this, or more confused at the end of this presentation, about what we do about that. Just lastly, we have a national reputation in this area. Dr. Essam is currently helping NHS England with developing their training for social prescribing link workers. We're one of 5 leading CCGs in the country, and we're hosting the regional social prescribing coordinators in the Midlands and East. And that's me wittering on at the all-party parliamentary group on loneliness in July. And it's really important that the loneliness strategy sees social prescribing as a key tool in addressing the problem. And then lastly, Marianne Essam and I got to go to Canada last year, not at the NHS's expense, I hasten to add. Worked with some community health centres out there, and they're obsessed with the social determinants of health. It was really, really exciting. But we did a bit of work with them on social prescribing, and they just won the first ever International Social Prescribing Award at a conference in July this year. So quite a good year, really.
Okay. You forgot your last slide.
Oh, sorry. No, that's not mine.
It's yours, Harold. Come on, Harold.
I do appear to be in it.
You haven't got a header slide for you.
No, I haven't. No, I've just gone straight into.
Okay.
So I'm here to talk about the HSJ System-Led Support for Carers Award. So my name's Carol Whittle. I don't work for the NHS. I work for carers in Hertfordshire. But we've been working very closely with the CCG right back before the CCG formed, really. This work goes back many, many years. So it was the Hertfordshire and West Essex STP, which you've already heard about, and it's about the integrated vision, pathways and supports. So what does that mean? It's all loaded jargon. What does it mean? One of the things that's been developed here in Hertfordshire is this 5-point carer pathway that everybody has signed up to. So that's the county council and all the various providers. And that's about identification, welcome, assessment and support, involvement, and particularly when things change for carers. So these are the things, and we're just going to have a look at, well, what does that mean? So around identification, these are the referrals that have come to us in the last year, 2018-19. And one of the things that's really very remarkable is the ones in blue are NHS providers. Whenever I go and speak to other people around the country, they're like, how have you done that? And we've done it through partnership and working very closely that, GPs and the community trust and the hospitals all working together to really identify more carers earlier in their caring journey. Welcoming them, just actually letting people know that you want to know that they are a carer. So GPs are doing that through notice boards. We've got badges that quite a lot of the health professionals wander around saying, let me know if you look after someone. There's a lot of different ways that people can do it, but actually just saying to someone who's looking after someone, we want to know about that and we're interested in it, is a really important first step. Carers health checks. That's one of the things that's being provided. Really important. It shows carers are at risk of many different things, including stress, anxiety, depression. And actually, medical care is not always the best answer. Sometimes it is that social support that really is the best answer. So this is actually taken off one of the websites of one of the GPs in Herts Valleys. If you recognise it, if it's yours, then yeah, well done. Because it's a lovely thing saying, do you look after a family member, friend or neighbour? If so, book an appointment for a health check. And that's really kind of important. It's one of the things that's going on around. Involving carers. Talked a lot about that, about in their general involvement, actually, but involving carers in their care. That happens within surgeries, within the PPG, but also within surveys. So there's been the GP survey, there's been carers surveys done and things by the Herts Valleys, and actually hearing what their issues and what will make a difference for them. Wider, there's the Carers Co-Production Board within Hertfordshire that works together, carer forums, surveys, national and local. And if you're particularly interested in carers and health, I've got some copies of our survey which we did in 2018 around carers' health, and that does include things like they are much more likely to miss their GP appointment or miss their hospital appointment, and that's something that we really need to be working on and making sure that that social prescribing helps them to actually get along to those appointments. So thinking about when things change. Often people think of bereavement as being one of the changes, and that is a big change for carers. If you've been caring for 20 years and the person you care for dies, that's a massive change, and you're going to need some support. It's one of the reasons why we as an organisation support people for 3 years post-bereavement, because we know it can take a long time. But also thinking right from our youngest carer is age 4. Our oldest one is in their 90s. This is, something that affects all ages across the board. So actually, for some, a change is starting school. For others, it might be changing school or leaving school. Moving home, leaving work, that's a massive one. Often, and that's also true for your NHS employees. Holding on to them is really important, so identifying them in the workforce is another really important thing, and it's one of the reasons why the CCG signed up to the Carers UK support for employers for carers. Changing relationship. if you have been husband and wife and now you become carer, that is a big change in the relationship, and people need support through those times. Cared for going into residential care, it's a really big one again that carers are telling us about, making that choice that you can no longer manage in the home, and that someone needs to go into residential care. All of these are times where people need additional support, and actually, people being aware and, making the referrals is really, really important, as well, of course, as bereavement. That one didn't come up quite right, but never mind. What it actually says is carers aren't asking for the moon. They are just asking for those 5 points to happen. And we've been really pleased that working with Herts Valleys over many years, and now with the STP, we're starting to see those changes. But obviously, we want everyone to keep on doing it. Thank you.
Ooh, wrong way. Not the best of starts. So, hello, I'm Sarah Crotty. I'm Head of Medicines Optimisation at the CCG, and I wanted to give you a whistle-stop tour of the things that have been changing within Medicines Optimisation over the last 18 months or so. Particularly wanted to focus on the good things that have been happening. So we had a very broad consultation with Let's Talk in 2017, which enabled us to ask our population whether they were prepared to consider a purchase of most over-the-counter medicines for short-lived conditions. We had a really resounding yes to that, and I think it's important for residents to realise that that across Hertfordshire has saved £500,000, which has been able to be invested back into our services. So a really big thank you for everybody, because this is lots and lots of small things that make a big cumulative financial effect, and has helped us to get back into financial balance, as Elke mentioned earlier. The other thing we're trying to focus on within medicines, because medicines are the most common intervention within health, is to think about reducing any waste that we can. So lots of people, when they order their repeat medicines, order every medicine. So the first message we're trying to give is that you don't need to order anything that you don't need. But if you do accidentally order something that you already have at home, if you return it to the pharmacist before you leave the shop, then it can be reused. But if you take it home before you return it, then it can't. So we're trying to really make people aware of this, so that people, if they accidentally overorder, can return it so it can be used and not paid for effectively by the NHS. So we've got these posters that are across the whole STP, which are being used in community pharmacies, and we're trying to encourage the staff in community pharmacies to get people to just check through their medicines in the shop before they take them away. Sometimes it can be really simple things that make an impact, and we think this is just the right thing to do. So we're trying to work harder with integrating with our local hospital, and we have always worked closely with particularly Watford General Hospital, but we've taken more strides recently to try to integrate the choices of medicines that are used both in hospital and in primary care. So we now have a published formulary which is on the World Wide Web that anybody can look at, that helps us patients, clinicians, whoever, to have a one-stop place where they can look at which medicines are the ones that we recommend. And then to link up with what was mentioned earlier about care homes, we have a small team of pharmacists and technicians, pharmacists who help to review medicines and personalise care, look at the patient's needs and wants in a care home environment, which may have been different. So we often find that people enter a care home and are on an absolutely enormous list of medicines. Record is about 57 medicines for one person, which is obviously almost impossible to take in the way that is intended, but also perhaps prioritising for that patient the medicines that are the best for them and the ones that are most essential will mean that those are actually likely to be taken as intended. So we have a small group of pharmacists that review medicines in the home and then work with the residents and with the GPs to try to streamline those medicines and have a more manageable list of medicines that the patients can take. This also helps to release the carers and the nurses in homes so that they can actually spend a little bit more time with those residents on the nursing care rather than spending a lot of time administering and recording the administration of those medicines. So we've over time gradually expanding that team, and we worked out that not all of the team needs to be pharmacists to do some of the process work that we do within care homes. So we work with the nursing staff around good processes in homes to make things safer, to make sure that medicines are stored safely, and to improve the quality and standards in care homes, with the aspiration that we're hoping that more of our care homes will achieve good and outstanding status in their inspections. As a side product of that, the technicians also reduce waste, and this is because they're good at synchronising the medicines and stopping people throwing medicines away that don't need to be thrown away. I think care homes are really complicated, and I really like this slide because it shows who you need to liaise with in a care home to get care organised in a care home, and it's really, really complicated. So I just came across this and I thought it was quite a good illustration of how, a bit like with the social prescribing, linking things together can make a real difference for patients' lives. And then finally, I just thought I'd do 1 minute on what's next. We have a real focus on frailty at the moment. I think it's clearly the right thing to do. We're not just talking about old frailty, we're talking about all frailty. So it includes mental health, it includes younger people, it includes people that need carers. But really, from the medicine point of view, we're going to be looking at reviewing more of the frail patients to make sure that they're having the right medicines and that we're maximising the benefits that patients get from those treatments. That's me.
Thank you. Thank you very much. My name's Thomas Galliford. I'm a consultant in West Herts and in the community. A bit of a sea change here because we're going to talk more about integrated care, and thank you very much for inviting me, because I think we are a good news story, and that's what it's been sold to me as. So I'll show you. So I represent an integrated workforce, which is West Herts Hospitals Trust. Where's my pointer? The community Herts HCT, and Herts Parson, as well as the GP Federation. And so I'm the clinical lead, and I'm joined in the back, who can take questions later, Maggie Carroll, who's the nursing lead. But this was commissioned, and we started this off in April 2018, but it's been a real journey, and this has been going on for many years, and that involves the CCG and the GP lead and diabetes as well. And it's predicated on the basis that the vast majority of our patients are not ill. They have diabetes. That doesn't necessarily mean they're ill. And also the vast majority of patients are seen in primary care. And so there's no point in us living in our ivory towers in secondary care. We need to be out in the community, and we need to see the right patient in the right place in the right time and as soon as possible. And so that has been the vision, and that's what we've been trying to achieve. We've done that by working together and smoothing the processes, but also it's hopefully supporting primary care much more. So our patients, and they are all of our patients, get treated correctly wherever they're seen. So upskilling primary care, supporting primary care, giving answers to primary care, and which also means that we don't have to have unnecessary visits to and from the hospital or wherever they're seen, and also being in locality, so having community services that are around and about, and working with all the people that we've heard from already. So we've got together and done that. This is some of the new service that we've offered. By no means all of them. So we're running multidisciplinary clinics in community settings. The diabetes nurses are allocated to localities and are going into primary care and seeing patients there with practice nurses. We're upskilling practice nurses. We're delivering an education program for primary care. We're giving advice and guidance virtually, so information technology, which we've had support from Trudy, I don't know if Trudy's here, has been vital to this. We're doing group starts for therapies, which is good for patients, well known to be better for patients, easier for us actually, better outcomes. We're going into nursing homes, we're speaking to practice nurses, we're getting our dietitians to give more information to our patients about carbohydrate, rather than you see them once and then you fall off a cliff, you can go back and see them again and learn more and more. And we've got some mental health support for our patients as well, which is excellent. So these are a couple last two slides. So this is out of date and it's a bit fuzzy, but what it shows is that waiting times have come down. They've come down further actually, and we'll continue to strive for that. We had a problem in Herts Valley. Our patients unfortunately do get complications to their diabetes, and you will have heard of problems with the diabetic foot. It's still the greatest cause in the UK of non-traumatic amputations, and we weren't doing very well on it. So we've instituted a number of different strategies to address that, and what I'll show you very quickly is how things have improved. The way of thinking about this, though, is about thinking about the patient with diabetes, and that's our friends and colleagues and relatives, and how this impacts on their everyday life. So we can see that admissions still happen, but we can see the number of inpatient admissions between before we developed our new service and since April 2018 has dramatically dropped. The total number of bed days, that's people staying in hospital, has over halved. Readmission rates have dropped, and they're seen quicker by the specialists when they present to hospital as well. Unfortunately, we still see amputations, but we're seeing many more patients in an outpatient setting, and patients are very satisfied with their care. And so that talks about clinical outcomes, but what actually that also manifestly comes out to is a health saving as well. So by keeping people out of hospital, we save money for the entire sector. So I'll stop there, but thank you very much.
Okay, just to close, so thank you to our speakers. It's great to hear, and it brings absolutely everything we're trying to do to life. So we're very passionate about allowing other people to present at these forums. So hope you enjoyed their presentations. So just to finish off, I'm going to take you very quickly through the vast array of the other things that we have done in the different areas that we would expect us to have picked up this evening, and then take time for a few questions. So quality are one of our third strategic objectives, as you would naturally expect, but clearly an absolute responsibility around the delivery of safe, good quality services. In the last 12 months, we have spent a significant amount of time and extensive engagement on hospital plans, and the submission of a strategic outline case around Watford hospitals. Many of you have joined lots of those engagement sessions, so I will move swiftly on. But obviously, we've had the opportunity at the moment now to have some much more clarity around accessing investment, which we believe is really good news for the patients who've been waiting a significant amount of time in this part of the world. Urgent emergency care, it was referred to earlier as one of the key areas in the long-term plan. We have actually invested about £10 million in urgent emergency care in the last 12 months. Some of that is in hospital. Actually, a significant proportion is out of hospital, and increasingly so. So in hospital, we're very proud of the fact now we actually have a sustainable delayed transfers of care. It's a DTOC target. So we previously never ever have hit that in this part of the world. And a significant amount of time working with the Trust in order to be able to manage the demand that is ultimately coming through the door. And then outside the Trust, we've, as I've said, supporting the community, not least some of the things that you'll see out and about, like ECP cars. So that's your ambulance drivers in their cars, rather than ambulances themselves, and mobile paramedic support, particularly also supporting care homes. We've also expanded with the County Council our specialist care at home and early discharge scheme, and also an extensive programme with GPs in trying to help manage those patients who are frequently attending A&E and ultimately preventing admissions. A huge amount goes into this, as you would expect, on a daily basis, and will continue to do so. Frailty, it's been touched on a couple of times this evening, but actually is an enormous project that we do, and everything that we commission now has this link. There is an enormous growth in the frail, and as we've talked about, frail doesn't necessarily mean old. And actually, the aim really is and the last financial year is about identifying patients in GPs and assessing them in order to be able to proactively provide the support that they need. And what we have done then is commissioned a number of services to support them in that. Some of them are just starting, some of them will be commissioned and developed as we go along. So, for example, there are frailty pilots within each primary care network and community vulnerable care coordinators, and rapid response rolled about West Hertfordshire when the end of life and the hospices, and intravenous antibiotics in the community to avoid hospital admission. So lots of things going on in this space. It is a major STP objective, and as you can see from the way Sarah talked about meds management, it's a thread of everything that we do. End-of-life care, as I've touched on, we actually invested $870,000 in the 7-day rapid personalised response service. Actually, we've just done the review of the pilot, and I know the 3 hospices are here. Yes, absolutely. Delighted with the results. Been phenomenal achievement by them, and ultimately now a 7-day service that we never had before. So very well done to our voluntary providers there. And there's been a decrease in the percentage of deaths with 3 or more emergency admissions in the last 3 months of life. So again, significantly down, and another stat that we really monitor really carefully for obvious reasons. Mental health, and I think if you roll on 12 months, you're going to hear even more about this, particularly around crisis management and also CAMS, so children and adolescent mental health. We have been successful in achieving most, not all of our targets, CAMS in particular, access to IAPT, but in reality we have actually been successful in a number of things in leading the way and trailblazer sites across all of our mental health space. Some of you will have heard about Just Talk and the publicity campaign that we did around boys and mental health, but we've also been part of a trailblazer site in a number of different areas, and those sites will increase. We've actually been successful in gaining further investment there, but this is going to be a continued investment and a continuing development in order to respond to what is in some cases an increase of about 30% in demand. So a significant challenge. And in that, we also focus on areas that are particularly important to us. And in 1819, we commissioned specifically support for how staff and services go the extra mile in ensuring patients receive personalised care. And for us, learning disabilities is a big focus for us. GPs are specifically targeted to provide health checks, and actually nationally we're one of the leaders, and you can see a 5% increase in health checks in the last financial year. Flu jab campaigns were all focused around learning disabilities, and we will continue to do that and try and set the lead. Continuing health, I actually was talking about it in another session earlier on today. We can't go out without saying how much work goes on behind the scenes here. We have about 500 patients who need continuing health care, and that is support either in the community, in their home, or in their nursing or residential setting. Actually, the team, from what was 3 years ago a very difficult position, have actually turned it around significantly, and actually have some very, very strong quality targets as well as financial targets in the way that they deliver, and I've been recognised by NHS England, so I wouldn't want to go out without mentioning their work. Maternity, children and young people, CAMS, some of which I've touched upon, but wanted to highlight, and last year we talked about community perinatal team, but actually in the last financial year we've developed a Healthy Young Minds in Herts schools accreditation, and we're delighted with the response from schools in that. And obviously it sits alongside all of the support that's going around the CAMS agenda and the trailblazers with NHS England I talked about a moment ago. So just to conclude with some of the performance, then these are more of some statutory targets, but also the wider targets that you will be familiar with. A&E, if that's the right one. A&E, you would be this one here, 4-hour wait in A&E. That consistently needs to be an area that we need to continue to improve nationally. The whole country struggles, but at the same time, it's a relentless focus on trying to make sure that patients get the access to the care they need as quickly as we can. Similarly, referral to treatment in 18 weeks. Actually, we've been in a relatively strong position and still are, but we are below the target of 92% and do a lot to try and outsource care as quick as we can into other providers where there are pressure points and specialties. Most of you will see on the left and the right there's a split of cancer targets. Some we deliver, some we don't deliver. Actually, Watford Hospitals, our main provider, have been very strong in delivering cancer targets. Predominantly the difference is actually on the patients who flow to East and North Herts Trust. But in the main, we actually have a strong cancer performance. I just also then, I've mentioned about delayed transfers of care, but dementia diagnosis rates. For the last financial year was the first year that we hit the national target around dementia diagnosis. So again, the whole point about identification, then patients can get access to the right care that they need. So finally, our last strategic objective around sustainable and affordable care. Clearly, the careful stewardship of our finances has meant that we don't talk about financial turnaround in our organisation and haven't done for the last 18 months now. We talk about financial sustainability, and that's the mantra that we have. And ultimately, that will create further efficiencies and long-lasting benefits for patients. And in that, a good example that we think is a really good evidence of how we have made a change ourselves as individuals is our move into the forum, which we worked on all of last year. It's in the local community here in Hemel. It has meant that actually we've downsized significantly by 50%. We've gone paperless, officeless, all those sort of things that you would expect. But most importantly, we've been able to invest public sector money back into the public sector, and we're closer to the communities that we serve. And lastly, then, our workforce. So I've mentioned earlier, we can't go without saying we have a huge enormity of people to thank, but ultimately the CCG team itself, but then all the stakeholders that we work with and all the staff that sit in there. It really is a team effort. As a system responsibility, we can't do this without everybody playing their part. But as an organisation, we've had some very positive results around our staff surveys again. 78% have said that they were always enthusiastic and are often enthusiastic about working in the CCG. And the HR team were one of the Team of the Year finalists nationally. And we've also had several people accepted onto accelerated development programmes. There's a huge amount of work that goes behind the machine for the staff itself in making them feel valued. So I'd just like to say a big thank you to them. I know a number of them are here this evening. So, what you're going to see next year, 12 months' time, we're already clearly halfway through the year and what we're working on at the moment. It is about going back to that cycle and the delivery of the long-term plan that Nicholas referred to. We are developing an acute frailty unit at Watford Hospital, linked to the frailty programme I was talking about. We are going to put an urgent treatment centre at the front door of Watford Hospital, and we have actually procured that with Watford Hospitals, and the aim will be to go live on the 1st of April. Similarly, we're developing more integrated urgent treatment centre opportunities for the MIU in St Albans and also with Barnet, not forgetting that a lot of our patients flow from Hertsmere into Barnet hospitals. We clearly have got the rollout of the adult community services I've referred to in 2 weeks' time. There is increased integrated urgent and emergency care for children and young people, so crisis management, and similarly then planned mental health support team for children and young people, particularly wrapped around schools and communities. And then I talked right at the beginning about services that are online, but more is following. And in that, you're going to see more developments in cardiology, respiratory, paediatrics, and dermatology. Thank you for listening. I appreciate that's a whistle-stop tour. Whistle-stop tour, wrong way round. And, but thank you. Right. I think do we have another mic? Louise? No, just one? Is that right? Right, we've got time for a few questions. Obviously, we'll be here for people to have any more questions if they'd like as well, or can obviously email us accordingly if they would like to at any point in time. So, okay, right, any questions? Hello, yes, hi. Are you able to shout? Yep.
Yeah, we are able to shout. What do they do about A&E in Hemel Hempstead? Why do we have to go to Watford for these things?
So there are a number of A&Es. Obviously, Watford Hospitals is one of which we commission. Clearly, a number of patients in this part of the world in Dacorum also go to Buckinghamshire and Stoke Mandeville. They also go to Luton and Dunstable. And I think, as Elquist showed, actually our acute spends lots of different places across the Herts Valley system. I understand your point around the Hebel and no A&E, but we do have a significant amount of investment in urgent treatment and primary care services, as talked about this evening, that actually is about the right care in the community for people who need to access urgent care. If people need to access emergency care, then clearly the services will also exist. I appreciate that's not as it was in Hemel A&E, but actually we do have a variety of other A&Es for people to access.
How's you spending all that money on Watford going to help us in Hemel and surrounding towns with emergency services? We ain't got urgent suite in Hemel. So why do I have to go to Luton for my child to be born?
So I think we don't want to spend the whole evening on reconfiguration of A&E. Obviously, the decisions around reconfiguration of A&E and the changes around that service configuration were made at a considerable time. What we're doing here is trying to invest in services that are accessible for most people at all times as possible, that they can envisage will do the majority of the care that they need. Primary care, community care, planned care, with mental health and all the things I've talked about this evening. Yep.
Facebook group started up literally just over a month ago.
Yep.
4,000 people begged to differ. They joined up in 1 month. 4,000 people begged to differ. Voting over in
I do understand your point of view. I absolutely understand and hear and listen to a lot of people who tell me, in particular communities in Dacorum, about the access to services around A&E. What I would talk about all the time is all the other services that are available. And actually, we have 680,000 people in our CCG that we need to provide services for. Sorry? Well, again, this is a question that comes up at... No.
I'm saying it should be centralised, so all the people, because do you have the Luton and Dunstable?
Sorry?
Is Luton and Dunstable under your CCG framework?
So we have a contract, no, but we don't oversee them, no. Yeah.
And you want to go to Luton and Dunstable because you've lost hope in Watford, because you know that you're going to wait,
Yeah.
and wait and wait. That's when you've waited, do you come in the ambulance?
Yeah, we do, yeah.
Because you say about not 4 hours in A&E, but if an old person that your big highlight in the falls, majority of the time, it's about a 6-hour wait for an ambulance. And our experience has shown that with my mother. But then you've got 4 hours wait to see a doctor. So that's 10 hours approximately that you're waiting. And you've had to go from your hometown, you've had to go over to Watford. If you get discharged in the night, you're left stranded. There's no buses running the night. It should be a centralised place. You should stop wasting money on Watford and emergency things, because you can't even, you say about this good rating, but the urgent care centre down at Hemel that opens 8 till 8 or 8 till 10, you can't even get GPs in there to cover the whole shifts anyway, because that's been publicised. So where is your good coming from?
Okay.
Please, I'd like to know, long time to wait for ambulances, long time to wait in A&E.
Yep, I understand there's a lot of statements in there, so at the end of the day, I want other people to be able to answer questions.
Big thing that you've made.
Yep.
Having gone through getting social care this year for my mother and carers, you're talking total, because it has been a battle, an absolute battle.
Okay, thank you. I hear what you're saying.
I think that you have a good rating.
Okay, I understand and I hear your point of view. Yeah. Any other questions? Katie, would you like to ask a question?
I had a question about the social prescribing, and really great to hear about that. I just wondered what work you do with children and young people locally, and if there's any opportunities around extending the social prescribing if it isn't already children and young people.
So those discussions are happening, and the way the service has been to date has been for 18 pluses, but NHS England have recently been making utterances about expanding that. Obviously, some of the high-intensity user navigator work is actually starting to look at 4-year-olds who keep going to hospital, and it's not about working with the 4-year-old, it's about working with the mum or whatever to give her the confidence not to do that when it's not necessary. So that sort of stuff is happening, but it's absolutely nationally something that we'll be doing more of. And the intergenerational nature of things, projects like Home Start are really interesting, because getting older volunteers to help new families, cope with their smaller children and learn some of those skills is a really good social prescribing model for the community, helping sort some of these problems out.
Thank you, Tim. Okay. Yes. Hi. Of course you can.
Also about the social prescribing. You said that community navigators and link workers are effectively the same thing. Will they be running alongside each other, or will it all be incorporated within the link workers? If you can answer that.
Actually, I think I'd like to say we're probably one of the few CCG areas in the country that can answer that question reasonably coherently. So we have the existing service of community navigators. There's about 20 in West Herts, and they are a mixture of the people doing complex work and simpler work. And they're all underpinned by Hearts Help, which is the system that helps people get to the bit of the system they need to get to. What's new about link workers is they will be based in primary care networks. So they're going to be taking, certainly initially, referrals just from primary care. So that will help bring primary care into that system more effectively than we've been able to do with just 20 workers for the whole of West Hertfordshire. They do currently, and it will be much... So the focus of those link workers will be the primary care networks. The other workers will focus more on issues which can be picked up through housing or whatever. And so we will move some of that around. But the system, it's all about one system. It's about saying, I'm not a social care granny, I'm not a health granny, I'm not a voluntary sector granny, I'm just a granny with a bunch of issues. And it'd be really helpful if I get treated as a whole person rather than a diabetic foot, for example, or whatever. And that's really what we're trying to do. And we're trying to fill all the gaps between all the stuff that... There's lots of lovely, lovely stuff if you fit in the right box. There's a lot of people who don't quite fit in any of the boxes, or have fallen out of boxes, or etc.
Okay, thank you. Right, any more immediate questions? Sorry, yes, Gordon. Yep. Do you need a mic?
Well, very helpful. Yes, good afternoon. I'm empathising with the comments from behind about centrally located emergency, and I'd like to refer to Catherine's financial document to spend. We've heard some wonderful stories, and they are truly wonderful, helping people in the community. But more than 50% of the money is spent on acute hospitals. According to this document, roughly 53%. And we've heard virtually nothing on it other than an inadequate proposal to tart up Watford. We need a centrally located, modern hospital that will increase your quality standards for now and for the future, so that you get a commensurate quality standard as you are achieving out of the community, also in the acute sector. Thank you.
Thank you.
What you see is a stupid place to have a hospital next to a Premiership League football club where there's so much parking, everything's needed. You might stick the quotas on paper, or even though the papers, but for real people ain't made of paper, people are real, and people are suffering. And I don't know who marks your tick boxes and classes you as good, but I don't think the general public and general population of Hemel, Watford and St Albans would give you a really good. And you are working for the people, not
Absolutely.
for yourself, for the people.
Yep, absolutely. And I am a West Herts Decorum resident, so I understand that exactly very well. So I think we've tried to show this evening the breadth and depth of a lot of work that's going on, particularly in the community. And yes, you're right, Gordon, 53%, that's not different from any other national average, but 53% of the acute spend is in the acute. That probably won't change, but actually what we want to do is try and make sure that that's the right spend, and that people, as growth continues, that people get access to the care as they need at the right time. We understand that might not be able to suit everybody's needs, in relation to where they would like local, particular A&E services. But that decision was made many, many years ago. And actually, what we're doing, and we've tried to demonstrate this evening, is that we're focused on delivering the right community and integrated care wrapped around patients and population and communities of 30 to 50,000, and we'll continue to do so. Okay, any other questions that we want to ask around? A none. Yeah.
I don't know if you can answer this. I noticed you mentioned the Stomp Initiative, which is a really great initiative, and I can absolutely applaud why you're doing it. I work for Citizens Advice. One of the things we do is help people with benefits claims. When they go for their assessments for their benefits claims and they have mental health issues, they'll be asked, are you on any medication? Are you getting counselling? And more often than not, if they're not on medication, the DWP will use that as a reason to say, well, you don't have a big mental health problem. So I was wondering if there'd been any kind of interaction with the DWP on, yes, we're doing something about reducing people's medication. That doesn't mean they don't have a mental health problem, stroke, learning disability, but it is a big thing they use.
So I think that's an incredibly important point, and I think that we as GPs, working with our patients and working with people such as yourselves, to try and actually get as much information as possible for the patient when they're actually having their tribunal hearings.
Yes, definitely.
And I think many of my GP colleagues would agree with the frustration of some of the decisions that are made.
Definitely.
And we try desperately in general practice to actually try and help patients to actually give them the information, because you're quite right.
There's some really good examples of that with some GPs are really, really good. Some GPs charge a lot of money for the letters as well, which doesn't help, but I think things are getting better generally with that. Okay. But yeah, so if you can provide that information that says why they're don't need that medication, I think
that's
can
a
help.
really helpful point. Thank you. I think it really is one final question, and I would ask actually, although I absolutely acknowledge the strength of feeling of the people that are here in terms of actually what they feel about hospital services, it would be nice to actually get some balance and actually hear if there are any other questions.
Mine's about my experience in Watford Hospital last year and how I was treated.
Okay, then that's fine.
Driveway. I was taken to hospital. I got there about 4:30. I didn't get a bed until about 2 o'clock in the morning. I was found to have 3 fractured discs in my spine. After wonderful treatment by the staff, nurses and doctors, I was told at 4 o'clock, after a fortnight there, I was going home at 6 o'clock. I said, how can I go? I live on my own. I said, my daughter has got my keys. I don't know where she is at the moment. Well, you're just going to have to arrange something, is it? Which I thought you had to have a package before you went home on your own. So that was the first thing. Then I was sent home, and then I got a letter to go to St Mary's Hospital in Paddington. And I said to my daughter, well, we can't go on public transport, I can hardly walk. We won't be able to go in the car because we won't find anywhere to park. We spent over £75 in taxis there and back, only to be told by the consultant I saw, who's a wonderful man, and he was very sorry for me. I don't know why Watford sent you here, we don't deal with your sort of thing.
Okay, so I think that's. So can I just say, I'm very, very sorry that you had such a distressing experience, and we will actually take some time outside of tonight's meeting to actually hear that in a little bit more detail and actually find a way of actually finding out exactly some of the lessons that have to be learnt. Okay. So we can take that outside. I'm happy to talk to you about it. Okay. Sorry?
Okay, sorry. Is there other questions that people have? Okay, so we've got two more questions.
Two more questions, that's fine. We'll start with yourself and then the gentleman at the front. Yeah, okay. Okay.
What we'll do is, for both the lady here. Okay. So what we'll do, so what we'll do is we'll ask the member of the communications team to just come and talk to you both individually. We'll take the details and then we can follow through on your experience with Watford and similarly try and resolve what we need to do with yourself around access. Yeah. So if I can ask one of the member of the team just to go and make sure we do that at the end, that would be appreciated. Right, last question.
My question is minor compared to what you've just been discussing, but you're sending all these services out to external providers. 4 have gone and 5 are going. Are you getting feedback so that what treatments you're having are going on your treatment record with your GP, so there is a complete record of what is happening? Because there is evidence around in the country that a lot of evidence is not getting back to the GP, and so future treatments may be compromised.
Okay, so I mean, I can absolutely answer that. That every single of our, community providers give us the information. There is often a delay from all providers, both in hospital and whatever, in terms of when it reaches. But I would say in general that our community providers are trying really hard and actually adhering to all of the contracts that we've actually put in place to actually get that information to GPs speedily.
So, okay, just to finish then, in the answer, so people, and we talked a little bit about data and technology, I think was brought up earlier by Tom, is that actually we need to, one of the things that we will switch on and are increasingly switching on is access to other community records with patients' consent. So in that, and if you've gone to see a community provider, an NHS or the otherwise, those records will be available for the GP to see in real time. And actually that already exists with Hertfordshire Community Trust. So yes, it's absolutely right and very important, essential quality care. Right, thank you. I'm going to close this evening. Thank you very much for your attendance. We do appreciate it. We do appreciate those who have strong views also about hospital A&Es, and thank you for voicing your thoughts. So if you do have any other specifics you'd like to talk to myself or any members of the team here, then you're very welcome to do so, or contact us otherwise, clearly. But thank you for coming, thank you for listening. And actually we're going to open the doors here, also because it's getting quite hot, but actually just to ease the exit, if that's okay, if we go out this way. Thank you very much, thank you.